Hi, everybody. Sorry that I couldn't be there with you guys to share in this wonderful meeting. Gordon asked me to put something together, so I'm going to talk to you about advances in PCL reconstruction with internal brace augmentation. And so my disclosures can be found on the Academy website. If you look at the biomechanical data on internal brace and PCL, this is a wonderful study that was done with Pat Smith's group. And they really brought to light the concept of synergistic load sharing. Everybody's worried about stress shielding of the graft, but if it's independent from the graft, you don't get stress shielding. And here's the data to prove it. So if you look on the top is blue, and the bottom is, which is the internal brace, and the bottom, which is the orange, is the graft. And notice that at lower loads, the graft is taking 100% of the load. And as you increase loads, the internal brace starts to share, but not completely unload, and hence the load sharing concept. So the key findings to this study was that load sharing occurs and peak loads are transferred to the suture tape, but not completely. And this resulted in decreased elongation by increasing stiffness of the construct. This is a study, another study that we did along with my old partner, Mike Stewart. And we found that adding the internal brace significantly decreased total elongation with cyclic loading and increased ultimate strength to failure. There's another study that we did with Rick Hatch in the USC group. And we did 10 matched cadavers, internal brace versus no internal brace, cyclic loading. And if you look at the internal brace group, significantly less posterior translation at every load. And importantly, compared to the intact state, no over constraint. For those that are interested in our all-inside PCL reconstruction technique, we published it in Arthroscopy Techniques years ago for this 5-minute video. Now, if we look at clinical outcomes of our PCL reconstruction with internal brace, this is our original series of 32 patients, 2-year follow-up, very good IKDC and lysome scores. Almost all of these were multi-ligament knee injuries. And read by an independent musculoskeletal radiologist, side-to-side kneeling stress views only showed a 1.1 millimeter side-to-side difference. If you look at our 2 to 5 year data on 50 PCL reconstructions and looking at IB versus no IB, we had no difference in graft failures or laxity or patient-reported outcomes. And look at our kneeling stress views. The IB group 1.8, the no IB group 2.6. Now, we didn't have enough patients to reach significance, but there's no question the trend significantly favored the internal brace group. Now, on a side note, we also looked up our ACL groups. These are clinical outcomes, almost 100 ACLs, 2-to-1 matched cohort analysis, mean age of 25, internal brace versus no internal brace. And the major difference we found was the internal brace group had a higher postoperative Tegner score. Now, I'm going to show you 2 quick cases of the PCL with internal brace. So this is a 16-year-old female volleyball track athlete. She already had a little over a year ago PCL and posterolateral corner reconstructions and comes to our place with persistent instability and a varus thrust. On exam, ACL, MCL, posterior corner were good. She had a 2+ sag and posterior drawer. Her LCL was interesting. It had a pretty firm endpoint. It was only a 1+ at 30 degrees, and her dial was symmetric. So the LCL wasn't too bad. So her exam was consistent with PCL deficiency and maybe mild LCL deficiency. And look at her thrust. I mean, that's a very significant varus thrust of her left knee. Here's her x-rays, and you can see she's got significant tunnel widening on the femoral side. Socket positions overall looked okay. And you can see here this big screw for the lateral side, which was bothering her as well. Hip to ankle film showed 6 degrees of varus malalignment. Posterior slope was normal. And here's her kneeling stress views with a little over 9 millimeter side-to-side difference. So that's consistent with a grade 2 injury. And here's her MRI. You can see that the graft was placed too high up on the PCL facet, so there's no lever arm there. And this is why the PCL failed, in my opinion. And if we're going to try to do this in one stage, we'd end up with a almost 18 millimeter socket. Here's the lateral side. The grafts actually looked okay, at least on MRI. And so you got a failed PCL, possibly failed LCL, didn't feel too bad, varus thrust, significant thrust, and malalignment. And what would you do? Well, we thought a two-stage approach would be better. Two-staged approach would be better. Stage one, a good exam under anesthesia with stress fuse, remove the PCL graft, bone graft the sockets, do a high tib osteotomy to correct her thrust and the slight amount of malalignment, and then come back and do a revision PCL and possibly revision LCL if needed. So here's her exam under anesthesia, and you can see a 2+ posterior drawer. And here's her stress fuse. Lateral was actually not impressive. It was about 1, maybe 2 millimeters. Not bad. And here's her drive-through sign. She had no drive-through sign on the lateral side. So I'm thinking, wow, that LCL may have hung on. Also, her ACL was intact. So we went ahead and reamed her out, put in some bone graft dowels for the femoral side. Same thing with the tibial side. We bone grafted the tunnels. The tunnel was way too high up on the PCL facet. And then we did the high tib osteotomy, 6-degree correction. Notice the posterior sag is persistent there. And then here she is about 6 to 8 months later. Again, residual posterior sag, but the osteotomy is healed. The bone grafting looks good. And then we did a revision PCL reconstruction with internal brace augmentation. It's got a nice big beefy PCL there. And here we are with final fluoroscopic views. And notice now that there's no posterior sag, the joint is well reduced. And here she is at her left knee, and this is about 8 months post-op, and she's got a completely normal gait. Here's the last case I'll show you. This kid, he was at a water park, and he's wearing these sticky water shoes, so you don't like fall when you're running around the park. And he's going into that tube that goes like flying down high speed, and he leans back in the tube to get a little bit more speed, and his sticky water shoe catches the top of the tube and dislocates his knee. So that couldn't have been a fun moment. And unfortunately, he took out the artery with the CT angiogram here. So at the outside facility, they did a bypass graft, fasciotomies, and a fixator, and then he transferred the patient to our place for ligament reconstruction. And the problem is he's got a vein graft now right in the back of the tibia, right where we're going to drill a 12-millimeter socket. So I had the vascular surgeons on standby and the vascular instruments actually in the room. You can see here a very significant side-to-side difference with his posterior drawer, so that's a grade 3. And then we get all the way down the PCL facet. I get the guide in place. I get the retrocutting device in place. I ream the socket. And I'm looking at 9-0 prolene sutures. How we didn't tear that thing, I don't know. But there's the anastomosis. And somehow we managed to clean it, but not go through it. So I think we got very fortunate on that day. So here's his all inside, all socket, ACL and PCL reconstructions with internal brace augmentation. And then for this, for the lateral side, we use a technique that Bob Marks and I developed years ago. Bob Marks from the Hospital for Special Surgery. And this was anatomic sockets, 1 graft, fibular based. We started doing this in 2003, reported our early results in 2009, and then our 10-year data in 2018, minimum 10 years. And 7% failure rate, which is the same as the Laprade-Ingebrigtsen technique failure rate. So it's been a very good graft source for us. And here you can see his ACL, PCL lateral sided reconstructions with no posterior sag. And here he is. This is just shy of a year from his surgery. And you can see here that he's been able to return to high levels of function. And these are the kids that really inspire us to keep doing what we do. So with that, for those that are interested, I think that you could certainly find this video online, PCL reconstruction with the internal brace. And there's no question in my mind as a take-home point that internal brace has become a standard of care in my practice for ACL and PCL reconstructions. I've been very happy with the outcomes. I think the biomechanics and clinical data clearly support it. And with that, I thank you very much for your attention and have a wonderful rest of the meeting.